So thank you all for joining. This is an overview of and orientation to the neurologic assessment tools that are being used by the site neurologists in PumpKIN. Just by way of introduction, I'm going to move to the first slide, which is a definition of the protocol-defined adverse event. And the reason I'm starting with this is so that you'll understand what the purpose of the protocol assessments is, so that it's possible to classify in an unambiguous and objective manner any type of adverse neurologic event. So you'll see here I have definitions of broadly described events called neurological dysfunction, and these arose from historical definitions in the, oops, I lost my thing here. What happened?
Sorry,
ladies,
there we go.
There we go. Okay. So the definition of an event of neurologic dysfunction is any new, temporary, or permanent, focal or global neurologic dysfunction, and it's to be identified and characterized by use of a standard neurological history and examination performed by neurologists, and I've also put here or other qualified physician. For purposes of this trial and your role in it, this assessment will be performed by you, the neurologist, and you are encouraged to use any results from clinical diagnostic testing to help you with classifying the events. The procedure would be that routine critical care staff should be incorporating neurologic assessments and should have a standard protocol for the clinical care of children with altered or suspected new acute neurologic events as part of their routine care. The procedures that are, someone just joined? Someone just joined? Nope, okay, I'll carry on. I want to emphasize that the role of the site neurologist is either in parallel with and not the same as that performed by the clinical neurological providers. If it happens that you're the person on call for the standard clinical care and you want to incorporate your study procedures into your routine clinical care, that's perfectly fine. But whatever you're doing as part of the study should not substitute for, but should be in addition to the routine clinical care. So for what's important here then is for a very well worked out system of communication between the clinical care providers and the study team as to when it's necessary for you to come in and do your planned protocol assessments and to respond to events. So that is not something within my scope to tell you how it should be done, but I just urge all the site neurologists to nail this down very, very in detail and very clearly with the clinical care providers and the site study coordinators. So for whenever a new neurologic symptom occurs, the ICU team should proceed with their normal clinical care and get a neurologic consultation, which typically involves a physical examination, imaging, possibly an EEG, and laboratory studies. And then it's up to the site examining neurologist to classify the event according to all of that data as well as their study exam. To everyone on the phone, please feel free to interrupt and ask questions if I've led you astray and you don't understand anything. So the next slide just defines the categories of neurological events. Again, this is a standardized approach that's done in many trials involving device and cardiac support devices. So there is potentially a transient ischemic attack, which for our purposes is defined as a transient neurologic deficit, clinically evident, that's consistent with an arterial distribution ischemia and that resolves within 24 hours and that has no infarct on brain imaging. And I just want to emphasize that because there may be instances where a child has a deficit that resolves clinically within 24 hours, but there is an infarct on imaging, and that is classified as a stroke and not a TIA. So the parallel definition then of an arterial ischemic stroke is a new acute neurologic deficit, or it could be just global encephalopathy or seizures because that's the typical presentation of a stroke in a child under 6 months of age. of any duration, as I emphasized under transient ischemic attack, where there is a associated acute infarct on imaging that corresponds with the clinical deficit. And sometimes children can have a venous infarct, but more often they're going to have an arterial distribution infarct. And then children can have an acute symptomatic intracranial hemorrhage, and that definition is fairly straightforward. Children can sometimes have a CT scan for some other purpose, and they're found to have, by chance, had a ischemic stroke that wasn't evident earlier, but that is noticed on imaging obtained for some other reason, and so we classify that as a clinically covert ischemic stroke or hemorrhage. Then there are children that can have a global hypoxic ischemic encephalopathy, and this would be something we might see after a cardiac arrest, for example. And then there's some other neurologic event which doesn't fit into any of these other categories, such as, for example, meningitis, a toxic metabolic problem, or a drug-related process. And then finally, there's brain death. So we have a separate, distinct category for brain death. Next slide is just a summary of the three types of clinical neurologic assessments that are mandated by the study. One is the pediatric stroke outcome measure, and this is just a standardized way for you to record and classify the results of a standard clinical neurological examination. And it must be performed in person by a neurologist. The study calls for three time points, or three types of time points. One is a baseline pre-implant, and this is ideally done within 48 hours of implant. It sometimes happens that the child deteriorates too quickly for you to do an exam, and so in that case, then you do the earliest exam you can as soon as the child's implanted. And then there's an exam that's called for in the event of a new acute event while on device. And then there are scheduled study endpoints at day 180, if they're still on device at day 180, and then there's 30 days post-explant, and then there's, or just prior to discharge, whichever comes first, and then there's a 12-month post-explant. And these are planned neurologic assessments. And the hope would be that at these study endpoints, the child would be alert enough to give you a standard, true reflection of their function. Now, the PSOM is meant to provide a global as well as information about localized deficits and overall functional impact of those deficits. To complement this kind of detailed clinical anatomical exam score is the Cauchy. And the Cauchy is very similar to a Rankin or to a Glasgow outcome scale, or to anyone who's familiar with neurocritical care or critical care, the PCPC. And it's just a stratified 5-level kind of global assessment of the child's general function. And it's meant to be done pre-implant, and the Cauchy can be ascertained basically from parental interviews, so you don't necessarily have to do a physical examination. And then the next one is at day 180, and then at 30 days post-explant and 12 months post-explant. And I'll go through the Cauchy in more detail. Now, the third item is the recovery recurrence questionnaire. We aren't really so much interested in or focusing on recurrent stroke, but rather this is just a proxy, and it's a telephone or interview-based assessment that mirrors the assessments captured by in-person physical exam by the PSOM. And it can be done by through parental interview, either by a neurologist or by a trained non-neurologist who's a member of the study team. And this is really just a backup way of capturing outcome in the case where children cannot come in person and get the PSOM. Any questions so far? Okay, good. So moving on to the actual exams. Make sure. Yeah. So the PSOM is short for the pediatric stroke outcome measure, and you'll find in this trial we've designed two versions, one to be done for children who are critically ill, and so that's going to be pertinent for in some cases, the pre-implant baseline if the child is very ill, or it's going to be relevant if the child is being evaluated for an event. And so that's a somewhat shortened version of the larger PSOM, and it is meant to characterize and allow for confounding factors. But basically, they're similar to each other in overall structure. And so what you do is you perform just a conventional neurological exam. There's nothing fancy at all about the neurological exam. You would approach it like you would in any clinical situation, and you would then just record the findings of your examination on this systematic form. And then you, at the end of it, you are asked to classify the results, kind of global results of various functional domains, so that we can come up with a score from 1 to 10 that captures the degree of impairment or abnormality on the exam. So please don't be terribly overwhelmed. If you open up one of the PDFs that you were sent by email, and if you look for the one entitled PumpKIN Critical Care Neuro Exam Form, what you'll see on that exam is basically instructions and then room for you to capture using basically check marks the various domains and elements of the exam. So I'm going to kind of move to the next slide. So the first page of that form indicates or asks you to check off if the reason for the assessment, if it's baseline, surveillance, which really isn't going to be happening so much, or in the case of a new acute event, or as a study endpoint. And if you're doing it for a new event, you're asked to indicate what was the actual type of new event, either altered mental status, a new deficit, seizure activity, or some other thing. And again, this just kind of gives us data on how children who are on device, who experience events, what their kind of general way of presenting is. And then you're asked to indicate what conditions might be present that might alter or confound or affect the interpretation of the child's exam, and you would just check off any that apply. For example, child's intubated and ventilated, they're being sedated, they have major organ dysfunction like heart failure or hypoxemia, or if they're just in the midst of recovering from general anesthesia for procedure or some other thing. And then you go on to the actual exam, and the instruction here is that for each item on the exam, if you have the scale, if you have the form open, and you'll go down to section 1, which is level of consciousness. For each of these broad categories, you're asked to check off whether the findings on that element of the exam fall under one of 4 broad categories. Either it's normal for age, or it's abnormal in a way that's expected. For example, a child who is sleepy because they're on some sort of sedating medication, but they're proportionately sleepy to that treatment. Or if it's abnormal in a way that is not necessarily attributable to their critical illness. And now this is a judgment call, so do your best, and I would just say you're all experienced neurologists and kind of follow your own clinical judgment as to which of those categories to fit into. And there's certainly going to be situations where you can't actually evaluate the child's level of consciousness. For example, if they're paralyzed for respiratory support. So in that situation, you would just click not done, not evaluable. And then there's room on the form for you to make some sort of note to yourself if there's some other extenuating circumstance that you think affects that exam. And then in the case that a child has depressed level of consciousness, we're hoping to get a little more data about how severe that depression is by asking you to record a Glasgow Coma Scale. And then under the section of cranial nerves, again, you'll have those same categories of abnormalities, so all you have to do is check boxes, normal, abnormal as expected, or abnormal, unexpected, or not evaluable. And you just kind of run through all of the cranial nerves. And again, you may not be able to evaluate all of them, so you just evaluate as many of them as you can, and check off those that are not evaluable as such. And then you have the motor exam, and you'll see here there's a way to lateralize, left versus right, central, upper extremity, lower extremity. You're asked to click off strength as well as tone, the presence of involuntary movements. The next section is tendon reflexes, and again, don't feel as though you have to check every single reflex. If you check off enough of them to classify the child as normal, abnormal, then you do what's, whatever is feasible within the time that you have. And the same pertains to the Section 5, which is sensory exam, and then language. And we have pretty basic broad categories for expressive language and receptive language, normal versus not, and then comment on any abnormalities, and many children will be not evaluable. And then really the important part is the summary of impressions. And under the summary of impressions, moving on to the next slide, we ask that you complete this section for all patients, including those for whom some sections are not evaluable. And certainly we want to know if your exam is consistent with brain death. That's going to be hopefully very rare. Or if you consider the child to be comatose, or if they have a global multifocal encephalopathy, a focal deficit, or if their exam is simply that of a sedated, acutely ill child without any kind of global focal deficit. And there may be cases where you simply can't be conclusive at all and your findings are indeterminate because the child is too heavily sedated or paralyzed to really do much of a definitive examination. And that may happen. So we just want to collect this information so that we can use the data that you submit in your scores and in your exam forms in a reliable and objective way. So for those patients where you have been able to do a fairly complete neurologic exam, then we ask you to apply a score for each of these broad domains on a scale from 0 to 2, where 0 means there's no abnormality, 1 means 0.5 is a minimal abnormality, but it's an abnormality expected for their illness, or there's an impairment that's greater than expectation. Under impaired consciousness, we've also asked you to check off if they're actually comatose with a GCS less than 8, and that will give you a score of 2. Or if it's just not evaluable, then you just put not evaluable. And you would do that for all the broad domains of cranial nerve function, sensory motor deficit, and you're asked to separately classify or score right and left side. And then if there are sensory motor deficits, we ask you to check off the type of deficit as shown by the checklist of global function. Oops, I'm one slide behind. Yeah, so I put up sensory motor deficit. Again, you would score right and left side, and you would then pick the type of deficit that you see. This again gives us a better idea of the nature of the deficit so that it can be adjudicated and classified appropriately. The same would be for language. And then finally, at the end of those, as you apply a score for each of those broad domains, then you add them all up to get a total score. And the highest would be 10 and the lowest would be 0. Any questions about the critical care form? And I want to just, again, emphasize that the form itself, when you record your exam findings, can be a little daunting, but it's just a way of collecting data, and the actual exam that you do would be just what you would normally do in a clinical situation to diagnose the localization, the type, and severity of that child's findings on exam. Can I ask if any of you, yeah. Go ahead.
Hey, it's Mike Taylor So we just had this question come up with a patient recently on a different device trial who was intubated a couple days after device implant. If you get the circumstance somebody comes in, decompensates quickly, is it preferred just to have as close to the OR exam as we can possibly get, or should we wait them out for 48 hours, get the best exam we can get post-extubation? And is there kind of a party line about how to do that?
Well, I have my own impression, but I'm not sure how it's actually written in the policy manual. Sandy, is that dictated in, in the policy manual and the procedures manual? No answer. I would say whenever the child is at a sufficiently recovered level from anesthesia, you think you can get a representative exam within that.
Seems reasonable.
Day
Yeah.
or two.
Yeah.
And and this shows the value of the COSHI, which is a complementary way of capturing the child's kind of representative level of function before their acute deterioration, and that's collected just by interview. Sorry, Sandy, did you have a comment?
I think Sandy had to drop off around this time, so she might have already dropped off, but I believe we say that it can be obtained up to 72 hours. So, yeah.
Yeah. What else was I going to say? So if you then, so that's the critical care assessment. And then, I was going to ask, do any of you, are you familiar with using the PSOM for other trials or other, like the IPSS data collections? Anybody, either of you on the phone?
Yeah.
Yeah, go ahead.
This is Sarah. I've used the PSOM before, and it's pretty straightforward. It looks daunting, but it doesn't take very long, actually.
Yeah, it's basically a bunch of check marks, and then you just collate your impressions. So onto the standard PSOM, and the standard PSOM is performed on a child who is basically awake and alert and able to function in some way. If the child gets to one of those time points where an exam is required, like 180 days on device, and they're still not really conscious or they're sedated, then you would use the critical care form to collect whatever data you can. So the more conventional pediatric stroke outcome measure is a somewhat more detailed exam, and it allows you to capture more information because the child is not sedated or intubated. And I'll just remind you that there are two age groups, so a different form for children under age 2 and a form for children over age 2. The overall structure and flow of the forms is basically the same. There's just slightly more options and items that you can include in your exam for older children. And again, starts with level of consciousness, behavior and mental status, and again, under behavior and mental status, you're going to have more things that you can look at. And again, none of these is absolutely required. You do as much of it as you feel is tolerable for the child in the exam situation, and whatever is enough for you to think you're getting a good representation of that child's function. You have the language function, you'll have cranial nerves, you'll have motor testing, right and left, and central, you'll have tendon reflexes, fine motor coordination, sensory, and then you'll have gait, again, scored according to the age expected norms. And then finally, you again will have your final summary of impressions. And under the final summary of impressions, as you see on the slide there, you score it similar, but usually you have a pretty reliable exam because you hopefully have an awake, functioning child where you can score right and left side for sensory motor deficit, none, mild with no impact on function, moderate with some functional limitations, or severe or profound missing function. And I left you the option of an indeterminate or not evaluable, but hopefully that won't happen very often in the situations where you're doing this exam. And again, for any deficits that you occur, we ask you just to check off any that apply as to the particular character or quality of the type of deficit that you're seeing. And then you'll have the same thing for language, expressive and receptive, cognitive and behavioral deficits. And we ask that you comment or just kind of check off if it's truly cognitive or if it's behavioral. And we all recognize that this is based on really a subjective impression that's rests on the experience of a qualified pediatric neurologist. The next slide is about the COSHI, the King's Outcome Scale for head injury. We've used this in a few stroke-related studies, and again, it's a nice complementary global 5-level functional scale that's similar to the Rankin. And for this study, or for this measure, we ask that the study neurologist do a baseline pre-implant where it's based on parent interview, and you ask them to reflect in their responses to the assessment what they think is the child's best level of function during the 3 months preceding the onset of their current critical illness. Then they get an assessment at 180 days if they're still on device, pre-explant time point if the child is awake and not intubated, a 30-day post-explant or just before hospital discharge, whichever occurs first, and then the same thing at 180 days, at 12 months post-explant. And then this just shows the items on the Koshi. The child's subscores are going to give you a broad category from 1 to 5, where 1 is death and 5 is good recovery or near normal. And I'll show you the reference there. For each individual of those classifications, death is self-explanatory. Vegetative is a score of 2. The child's breathing spontaneously, may have sleep-wake cycles, but has no purposeful or socially meaningful engagement with the environment. A score of 3 is a severe disability, and we separate them into 3A and 3B, where the child may be able to make some spontaneous or purposeful movements and is conscious, may be able to do a little bit but not able, and may be able to communicate. A 3B is that they have a very high level of dependency, but they are able to participate in some way. They may be able to feed themselves or walk with assistance or assist, but they still require a lot of support. Category 4 is a moderate disability, a child who's basically independent in activities of daily living, but may require some supervision or some actual help with certain things, such as a child with a moderate hemiplegia who is ambulatory but needs some assistance. Or the 4B is a child who's appropriately independent but has some residual definite deficits and neurologic sequelae that affect their function. And again, these are not particularly prescribed as to how you score them, and what we have found is that these are pretty intuitive for neurologists to classify children based on interview with the family, and in the ideal situation, it's also supplemented by your examination. But for the most part, you can come up with this kind of classification based on a detailed and careful interview. And then finally, category 5 is what we call good recovery. 5B means there are absolutely no problems whatsoever. A 5A means the child might have intermittent symptoms like headaches, might require some anticonvulsants. They might have some minimal abnormalities on exam, but those minimal abnormalities don't really affect their function. So a 5 is a pretty good score. So for the last is the Recovery Recurrence Questionnaire, and this is just a proxy for the Pediatric Stroke Outcome Measure. It is only done if the child is not able to participate with an in-person exam. And the exam or the interview questions were designed to mirror the final summary of impressions that you would come up with if you did an in-person exam. And the first is just a basic question that comes from an instrument called the Neurological. Has the child recovered completely from the stroke? Now, I think what I show on this slide is the question, has your child recovered completely from the stroke? In the case of this trial, not everybody's going to have a stroke. So I think I've substituted on the exam form, has the child recovered completely, and left it at that. And because I don't want people to infer or jump to the conclusion that their child had a stroke. And then if the answer is no, if the child has not completely recovered, then you would go on and answer the subsequent questions about whether the child has sensory motor problems. And under that, you would record an answer for both the right and left side and ask the parent to rate their degree of abnormality from no problem to mild problems without actual functional impairment to moderate to severe. And this, again, has been standardized and validated. And you would do the same thing for language expression, again, scored on a Likert scale. And for language comprehension, again, scored on a Likert scale. And then cognitive and behavioral things, again, these are very broad, subjective scores, and then you would then add up the total score. And I think that's it. So let me leave time for questions. If anyone has questions, you are free to and encouraged to look at the actual exam forms and correspond with me by email if you have particular questions.
For the overall, this is Sarah again, for the overall classification of events, one of the first slides that you had, is there, if the child were to have a seizure without any obvious etiologies such as stroke or HIE, would we classify that under other acute new encephalopathy? Unlikely to happen without an event.
Yeah, that's sort of your catch-all. It doesn't fit into any of the other ones.
Okay.
And hopefully when you make this classification, you would have access to any other testing that's done, and you would be, corresponding or getting information from the chart and the clinical providers if they were able to find that a child who had a seizure actually had a stroke and their symptom was due to the stroke, then you're able to nail down that classification.
Right.
Anybody else? Well, I'm eager to have feedback, and if any of you have questions along the way, I assume you'll all keep my email handy, and this is somewhat of a, we've learned how to do this as we do it. I'm reflecting my experience with a variety of stroke studies, but also with the therapeutic hypothermia after pediatric cardiac arrest, because we did something very similar, and the neurologists on that trial were fantastic and really adapted and were able to do a similar type of exam, and we came up with some good data on that, and it was quite reliable. So I'm hoping that this will go pretty smoothly, and it'll be minimally burdensome for any of you who are doing the study exams.
Great. And,
thank you so much.
We will be posting those, this training, the recording, as well as the PDFs that were provided to you right before the call on NERI Connect, so that they'll be available for future use. And for other people that weren't able to join, or others at your site that would find this useful, feel free to share. So we'll be posting that shortly.
All right. Well, many thanks to all of you for participating, and we look forward to working together.